Hello guys, today we will discuss about the next thing or the step in the gallbladder series, the gallstones, which is also called as cholelithiasis. Now, it is the most common biliary pathology, as you must be knowing. It is asymptomatic in 80% of the cases. Cholecystectomy, so it is the most common operation performed by a general surgeon because of the burden of the disease, and you must be knowing 4F or 5Fs to describe the risk factors, that is fat, fertile, female, 40, and now we include 50s also. For MCQs, Saint steroid is important, which is gallstone, diverticulosis of colon, and hiatus hernia. One more important question is why gallstone pain radiates to right shoulder. It is because phrenic nerve have the root value of C3 to C5. It innervates the gallbladder, and also the root value of shoulder is C3 to C8. So there is radiation of pain to right shoulder. One most important sign in this is Murphy's sign, which is done when the patient is in sitting position. So what is done is right hand is placed just below the right costal margin on the lateral border of the right rectus. Moderate pressure is exerted with fingers to palpate the gallbladder, and the patient is asked to take the deep breath. So the patient will wince with catching pain if the gallbladder is inflamed. Now, if it is done in supine position, it is called as Moynihan's method. Lavoisier law is very important. It states that in a jaundice patient, if there is palpable gallbladder, it is seldom due to stone. Exceptions are double impaction of the stone, that is one stone in CBD and other in cystic duct, like this. Cystic duct, CBD. Other is mucocele due to stone in cystic duct. So stone is in cystic duct and compressing the CBD also. Oriental cholangiohepatitis is one exception, and pancreatic calculus obstructing ampulla of Vetter. So this stone which is obstructing ampulla of Vetter can lead to jaundice with a stone. Now, types of gallstone can be defined as cholesterol stones, pigment stones, or the mixed stones. Western world, 80% stones are mixed or cholesterol stones, but in Asia 80% are pigment stones. So cholesterol stones or the mixed stones, these contain 51 to 90% pure cholesterol plus admixture of calcium salt, bile acid, pigment, and the phospholipids. The pigment stones are which contain less than 30% of the cholesterol. So this is the gallstone, which is having cholesterol in the main component. This is mixed stones, and this is pigment stones. So pathogenesis can be described as this: impaired gallbladder function, like emptying, absorption, or excretion will lead to gallstone formation. Supersaturation of bile will lead to gallstone formation. Age, sex, genetics, obesity, and diet. Cholesterol nucleating factors are mucus, glycoprotein, and infection, which lead to gallstone formation. Absorption or intrahepatic circulation of bile, like deoxycholate, bowel transit time, fecal enteric flora, ileal resection, and cholestyramine can lead to formation. So let's divide it into three things: lithogenic bile, nucleation, and stasis. The cholesterol is insoluble in water. It is made soluble by concentration of bile salt and the phospholipids in the bile, and also type of phospholipid in the bile acids. Now, what is lithogenic bile? Normally, bile cells formed by the phospholipid hold the cholesterol in a stable thermodynamic state, but when there is disturbance in this, the bile become lithogenic. So it can happen in cases where there is increased cholesterol, like obesity, high cholesterol, diet, low fibrate therapy, or decreased bile salts like primary biliary cirrhosis, OCPs, and genetic factors. Decreased enterohepatic circulation can also lead to lithogenic bile, like ileal disease, ileal resection, cholestyramine, and deoxycholate. Now, nucleation. Nucleation, when the cholesterol monohydrate crystal form and agglomerate to become macroscopic crystal. This occur in mucins, like due to mucins, non-mucin glycoprotein, and infection also. Stasis is other reason. This happens in prolonged TPN, fasting, pregnancy, OCPs, burns, and in surgeries also. Now, pigment stones. These stones contain less than 30% of the cholesterol. These are two types, black and the brown. Predisposing factors are genetic, hemolysis, cirrhosis, infection, that is E. coli and Ascaris, and chloronchis. Ileal resection or bypass can also lead to this, and cystic fibrosis is the reason. Black stones, they are overall 20 to 30% composed of an insoluble bilirubin pigment polymer mixed with calcium phosphate and calcium bicarbonate. Black pigments are calcium salts of unconjugated bilirubin, calcium bilirubinate, calcium palmitate, calcium stearate, as well as cholesterol. Brown stones are rare, you know that, because they form in the bile duct and are related to the bile stasis and infected bile. Now, insoluble unconjugated bilirubin precipitate, brown pigment stones are also associated with the presence of foreign bodies within the bile duct, such as stents or Chloranchus sinensis and Ascaris lumbricoides. That is, these are parasites. Clinical presentation are, you know that most of the gallstones are asymptomatic. When the pain is there, it is usually right upper quadrant or epigastric pain which radiates to back or the right shoulder. You know the reason why it radiates to right shoulder. So this is the typical presentation. It may be colicky, but often it is dull and the constant in nature. Dyspepsia can be a symptom. Flatulence also can be a symptom. Food intolerance, particularly to fat, may be a symptom. Sometimes in bowel frequency alteration is there, and biliary colic is typically present in only 10 to 15% of the patient. Now, jaundice can be there if the stone migrates from the gallbladder and obstructs the CVD. Gallstone can lead to bowel obstruction. In that stage, it is called as gallstone ileus. Acute cholecystitis, we'll discuss this in next slide. So it is what? It is symptom do not resolve but progress to continued pain and fever and leukocytosis. The differential diagnosis of acute cholecystitis are appendicitis, perforated peptic ulcer, acute pancreatitis. These were the common symptoms. The rare ones are acute pyelonephritis, myocardial infection, and the pneumonia, right lower lobe. Complications which are biliary colic, acute cholecystitis, chronic cholecystitis, empyema of the gallbladder, mucosal perforation, biliary obstruction, acute cholangitis, acute pancreatitis, and gallstone ileus. Now, diagnosis, you know that history is most important, and examination, Murphy sign, you can see that ultrasonography is the first test. CT scan when there is concern regarding diagnosis or there is perforation. MRCP can be done when there is jaundice. Radionuclide scan can only be done in acute cholecystitis. What is the treatment for this? It is safe to observe the patient with asymptomatic gallstones. Prophylactic cholecystectomy can be done in patients who are diabetic, those with congenital hemolytic anemia, and those patients who are undergoing bariatric surgery for morbid obesity can also be considered for prophylactic cholecystectomy, because it has been found that in these groups that the risk of developing symptoms is increased. So this is removed prophylactically. Other indications are the stone which is more than 3 cm in size, multiple CVD stones, polyp associated with stone, porcelain gallbladder, and immunocompromised patient. Acute cholecystitis is pain which is not relieving on medication, and there is leukocytosis and fever also. So non-operative treatment is based on the 4 principles. So acute cholecystitis patient, you can say whether to operate the patient or not depending on the Tokyo guidelines I'll discuss. But if you are opting for the non-operative treatment, these are 4 principles. First is nil per mouth and intravenous fluid administration until pain resolves. There is administration of analgesia. Third is administration of antibiotics as the sustenance is blocked. In most instances, the concentration of antibiotic in the serum is more important than the concentration in the bile. A broad spectrum antibiotic effective against gram-negative aerobe is most appropriate, like cefazolin, cefuroximone, ciprofloxacin. The 4th step is subsequent management when the temperature, pulse, and other physical signs show that inflammation is subsiding. Oral fluids are reinstated, followed by a regular diet. Cholecystectomy may be performed on next available list, or the patient may be allowed home to return when there is inflammation has completely resolved. Now, Tokyo guidelines assessment of severity of cholecystitis, it is done for. So Japan is having the Tokyo. So what does this say? It is severity for acute cholecystitis. So you have to grade it. Grade 3 it is severe, grade 2 moderate, grade 1 is mild. You can see this table from Bailey and Love. Grade 3 is severe acute cholecystitis. Grade 2 is moderate acute cholecystitis. Grade 1 is mild acute cholecystitis. So grade 3 is associated with dysfunction of any one of the following organs of the system: cardiovascular system, neurological, respiratory, renal, hepatic, and hematological. So it is acute. If any of the following are present, it is called moderate, that is elevated white cell count more than 18,000, palpable tendal gallbladder, duration of complaints more than 72 hours, or marked ileal inflammation or gangrenes. Grade 1 is when there is mild acute cholecystitis. So does not meet the criteria of grade 2 and grade 3, can be defined as acute cholecystitis in healthy person, and in this cholecystectomy can be safe. Now in grade 3, either operative intervention and cholecystectomy should be performed, or if the patient is unstable or comorbidity is there, a percutaneous cholecystectomy is done. The timing of surgery for acute cholecystitis remain controversial. Some advise early intervention, that is first week. Some advise delayed intervention, that is after 6 weeks. Early cholecystectomy during acute cholecystitis appear to be safe option and shortens the hospital stay, provided the operation is performed within 5 to 7 days. If early operation is not indicated, one should wait approximately 6 weeks for the inflammation to subside before operating. The sources for this lecture were Bailey and Love, internet, and the next lecture we will discuss about Meiji syndrome. Thank you so much for the patience.